3.2 billion base pairs of DNA that come together, right? The number's not important. You just need to know it's complicated. And 40% of the embryos that a donor creates, so almost half, are not genetically normal. They don't have the right amount of books of DNA to make a healthy baby. That's like you trying to build a house without the right blueprints. It's not going to go well. Those don't implant, so they're negative cycles or they're miscarriages. And this is really hard when you have surrogates that you screen and medicine that you bought, and your whole dream of your whole future family is riding on that. And I've been on that side of it. I've got 2 kids through the old-fashioned way, and then my wife and I had 3 miscarriages and ended up having IVF twins. So I know what it's like to be on the other side when it's supposed to work, but it's not. And the big secret is we can't control all this. We can't control all this. The biology can't be controlled. What we can control is setting up the conditions for success, is using the best, most advanced genetic technology to help you, is having the people who help you with donor matching, with the psychological counseling, with the coordination, with the pharmacy, having those people to be there to talk to you. And that's why our team is so big. We've got 25 people on our team that are just helping surrogacy cycles. Okay, and we're doing almost 500 transfers into surrogates a year. Those surrogates are coming from all over the place. Our focus is to do whatever we can to maximize the chance that you have a genetically healthy baby the first time you do that. So everything is designed towards that, and we're very picky about how the screening goes for surrogates and for donors and how it works with. And that's why we're selective about the agencies that we work with as well, because if we can't control the biology, we can try our best to control everything else, right? And so for you guys, what I want you to do is have a lot of conversations with a lot of people today about what matters. I will tell you, number one, genetics matters, right? That's really important. Live birth rates matter, right? The access to the team and the personal care, that matters too, right? Insurance matters, right? Understanding 1 versus 2. That's a longer conversation, but that matters too. So when you're talking to the clinics, ask them about the agencies. We have a B2B relationship. We work with them really well. Ask the agencies about the clinics. This is how you can learn. This is probably the most important thing you're going to do in your adult life. Yeah, jobs are important, house is important, but this is probably the most important thing. So don't be intimidated by the data. Do the research that you need to do so that at the end of the day, you're sleeping well at night, knowing that while everything can't be controlled in the world, we're putting our faith in the people that have the best approach and the best history of success in doing this. And you do need to know that this is the most successful process that we do. It is taking a donor and taking a surrogate. We accept about 4% of surrogates that we see medically. We accept about 6% of donors, and 99.9% of people do genetic testing. So doing that approach has led us to making the most healthy babies. And that's why this is such a fun thing for me to do, because I get to see excited, aspiring future parents from all over the place and make almost all of them happy in how we do this. And so that, let me see how we're doing on time. It is a few more minutes. One question that I've been asked 15 times already is, who do I start with? Do I start with this agency? Do I start with the clinic? And the way that we do things, in order to genetically test the embryos, we did a randomized controlled trial that got the prize paper at ASRM that showed that you get more babies if you freeze the embryos. And that's a longer conversation, but frozen embryo transfers are generally how this is done. That means that the donor can go through any time. We just need to have the sperm and need to be tested. If we're only showing you donors that have already passed everything, they are ready to roll, right? So you could come to Portland, you could choose your donor, and you could have embryos probably created by January, right? The rate limiting step of this for most people is actually the agency. And that's because I'm not testing you and accepting 4% of you, right? But I am accepting 4% of surrogates. There are more intended parents in the world than there are qualified surrogates, okay? And that's a good thing. We're screening the surrogates because we want them to have the best chance of having a healthy pregnancy, right? But it means that there's a wait time for a lot of agencies, and they can tell you what they all are. But if you sign in, it might be 6 months until you match. That just means that you picked a surrogate and they pick you. We've still got to do legal, which takes a month, testing of the uterus, which takes a month, medicines for the transfer, which takes a month. So if it's a 6-month wait to the match, 3 more months to the transfer, that's 9 months to your transfer. So if we go forward with the visit to you're probably going to go to your clinic one time wherever it is. It doesn't matter where your clinic is, right? If you need heart surgery, you go to the best place for heart surgery, which is probably the Cleveland Clinic, by the way. But and I'm from Cleveland. But you go to the best place, right? You'll probably go there once. Your surrogate will go to your IVF center once, probably for testing, and then probably once for the transfer. And then she's going to be at home where she lives. And because now surrogates are coming from a lot of different places, that means that you're working with a lot of different situations potentially. So pick what is the best place for you. Talk to a number of groups. Consider the whole team, right? Don't be sold by anything that anybody says. Do your research, do your homework, right? And figure out sort of what really makes sense to you. You're going to see different approaches. They all have validity because they're all created off of our own experience, right? But we're really thrilled to be a part of this. We were fortunate enough to see patients from about 35 countries. This is surrogacy is about half of my practice. It's a big part of what we do. One of Dr. Hessel is my partner. He does about half surrogacy as well. So, and we're happy to wherever you are, whatever your situation is, if we can help with questions about your particular situation, please just search us out. My email is pretty easy. It's brandon@ormfertility.com, and so I'm happy to talk to that. But let me stop and let me see what questions can I answer. Are there concerns about the PGTA? Does it hurt the embryos? Or what would be most helpful to talk about? Yeah.
So you talk about the independent variable being the probability of the genetic child. And I guess I have some questions about the facts around mean and variance relative to the general population. So the thing that we are doing, right, is a assisted surrogacy. Is the probability of a genetically healthy child assisted by technology materially different from the natural birth process in the general population, one? And two is there meaningful variation within the community of providers between ORM and others in terms of the probability of delivering genetic birth?
Yeah, so let me go backwards. So yes, absolutely, and SART clearly shows that. And if you want help looking at the SART database to sort of break it down, sort of analyze CCS testing, genetically tested embryos on surrogacy cases over the last number of years. When you really look at a clinic, don't look at just one little data point in 1 year. Look at everything they've done for the last 5 years, right? And if you email me, I can sort of give you the analysis that we've already done for that, which would help. To get back to the first question, fertilization is phenomenally complicated, and 40% of embryos from a 22-year-old woman are abnormal. By the time you get to be 35, 36, the majority of embryos that are created are abnormal. This is why half of 35-year-olds are infertile. Okay, so the best chance any woman has to get pregnant is about 22% per month. Okay, and at the end of a year, the youngest women, about 85% of them get pregnant, and infertility is the rest. Thank you. But if you look at older women, so many more of the embryos are abnormal. And so what you're not seeing is the fact that those abnormals don't implant or they miscarry, right? For us, those are negative cycles. So I think the best parameter is live birth per transfer, and it's clearly higher, in our program at least, if you have genetically tested embryos. We've got 2 minutes. Yes?
So you talked a little bit about PGT testing. Mm-hmm. After PGT testing, what's the chance of still having a miscarriage?
So with a single embryo transfer, so our live birth rates over the last several years have been about 70%, so let's say 30% don't. Of those 30, about half of them don't implant, so you transfer them and they're just negative, meaning that the ball of cells doesn't attach to the uterus and set up the blood flow that it needs, right? And then about half of those miscarry. Miscarriages and negatives can both be physical things, maybe it doesn't get to the right place, or maybe it doesn't get the blood flow it needs, or there could still be a genetic reason, right? The PGTA screens the information of the genetics. Genetics are they're organized into books. They're called chromosomes. You're supposed to have 46 of them. So picture a set of encyclopedias, 46. We're testing 3 billion letters in 1 million places. Okay, so we're not telling you that it's completely normal. We're not sequencing the entire genome of every embryo at this point. And the reason why we're not is because we wouldn't know what a lot of the information meant. And what we want to know is it's normal or not, 46XX or 46XY or not. And again, about 40% of them are abnormal. Sorry, you know, it's like numbers flying. It's nap time and it's hot in here. So my contact with my patients, like I said, it's a team sport. I have my donor matching specialist, my financial counselor, everybody that does their role. They all work under my supervision. I think it's very important that I see the donors. I talk to them about the risk. I make all the decisions on their cycle. I do the testing of the uterus. I do the transfer myself. Because the surrogates live all over, I can't do the pregnancy monitoring unless they're in Portland, of course. For the intended parents, the relationship that I would have would be that I'd probably talk to you about 5 times during the process. Maybe a new patient consult, maybe when you visit, once the embryos are made, once we're choosing a surrogate, maybe during the pregnancy. Really as much as we wanted to. Last thing I guess I might say is that it's critically important that you communicate in both directions. If you hear something, read something, if something's not going well with the donor, with the surrogate, with the agency, with the lawyer, please let your doctor, please let me know about it, because I can only help with things that I know about. And whenever you're at a distance, that communication, we want it to go in both directions. If you're upset because the coordinator didn't call you about the surrogate's period, well, maybe she didn't get her period. Or maybe the surrogate forgot to call. Because, again, there's a lot of moving parts, and our goal is to keep you moving from where you're starting to have that genetically healthy baby. Last question, quick, 10 seconds, anybody? If you want more information, Eras has packets in the back, and we can certainly take your information down. And again, Brandon at ORM Fertility, please feel free to reach out. But thank you so much. Really nice to see you today. I hope it's helpful.